I take the freedom to take a couple of minutes for another introduction of our second speaker, Associate Professor Kateřina Machová Poláková. She is Associate Professor at the First Medical Faculty at Charles University and Head of the Department of Molecular Genetics and the Biobank at the Institute of Haematology and Blood Transfusion in Prague in Czechia. Her research focuses on the molecular biology research and molecular monitoring of hematology malignancies with particular interest in or expertise in CML, including BCR-ABL1 transcript analysis, measurable residual disease monitoring, and the mechanisms of treatment response and resistance. She also plays a key role in international CML collaborative networks and reference laboratory activities, contributing to the development, standardization, and quality assurance of molecular diagnostics used both in clinical practice as well as in clinical trials. We're delighted to have you here again after the EHA highlights in January, and you will share with us the biological highlights of the meeting. Thank you so much, and feel free to share your slides.
Thank you very much. Thank you very much, Stephanie, for kind invitation and also introduction. And hello, everybody. I'm going to share my slide. So I prepared for you the biological highlights in CML from EHA 2026. And I would say that when I heard the research and saw the posters, I would say that the researchers focus on these three topics, let's say. So they focus to uncover the molecular mechanism or signature of leukemic stem cells persistence in CML. They try to uncover pre-existing LSC clones responsible for progression to blast phase CML in patients or diagnosed in chronic phase, and also studies on combination therapies to overcome BCR-ABL independent TKI resistance. Just briefly, I like to introduce these highlights. All we know that TKIs effectively target the BCR-ABL oncoprotein in CML cells. However, we still have patients who respond to TKIs inappropriately. And also we know that the patients, this is rare event, but the outcome is very poor, may progress to blast phase CML. And also patients in whom we may stop TKI therapy, they just 50% of patients remain in TFR, and other 50% roughly achieve molecular relapse. So we would like definitely to enhance the number of patients who optimally respond to TKI and who to enhance the rate of TFR. So we know that the population of dormant leukemic stem cells persist despite therapy, likely due to their quiescent transcriptionally low state, reduced or altered dependence on BCR-ABL signaling, and protection by the bone marrow microenvironment. And relapse may occur when these LSCs are reactivated by changes in the bone marrow niche, particularly inflammatory signals and or through genomic instability during hematopoiesis and clonal evolution. And this can lead to additional aberration beyond BCR-ABL that reduce the effectiveness of TKI monotherapy. There was a very nice education talk provided by Dr. Mile Schemionek-Reinders from Aachen, Germany, and she focused on the crosstalk between CML and the niche. And in this picture here, you can see exactly that there are two different outcomes of patients in whom we may stop TKI therapy. Some patients failed TFR and some achieved TFR. And it definitely, the difference must be, the difference is in leukemic stem cells fitness or permissive niche, and it is also about the contribution of immune control. And it is known that CML remodels the stromal and vascular microenvironment, and the key role plays here the mesenchymal stromal cells and adipogenic progenitors. And Mila focuses on, during her talk, on myelofibrosis that is quite frequently occurred at the diagnosis in CML patients, which is she showed associated with outcome after TKI cessation. So patients with bone marrow fibrosis were more likely to relapse after TKI cessation compared to patients without. So fibrosis reflects a niche favorable to leukemic stem cells persistence. And also she showed that the LSC expansion and myelofibrosis share inflammatory pathways. Megakaryocytes are increased in CML, and the number of megakaryocytes positively correlate with myelofibrosis greater than BCR-ABL copy numbers in CML and drive fibrosis in BCR-ABL negative myeloproliferative disorders. Her colleague from Mirla's lab, Dr. Bieni, she performed experiments showing that a CML-associated megakaryocyte promoted angiogenesis and fibrosis associated changes and showed increased production of tumor growing factor beta and contributed to both stem cell quiescence and disease persistence. They also found elevated CD36 expression in CML and case, and that selective blocking by antibody of CD36 really in this in vivo mouse model, they showed that it significantly decreased the spleen weight and really contribute to overcome this CML progression in mouse model. So the final message from Mila Shemionek's talk was that niche-directed therapies may complement TKIs in the future with the aim to eradicate persistent leukemic stem cells. The other talk that was really nice was provided by Professor Tiong Wong from Singapore. He focused on their group. His group developed the multicolor flow cytometric analysis that in my eyes, may be really in the future established in the labs to perform important analysis regarding to uncover and to identify high risk chronic phase at the time of diagnosis in patients who may be in risk to early progress during TKI therapy. And there was also a nice talk from Elaine Sao from Tiong Wong lab, showing that they are very skillful in a single cell analysis because they can simultaneously assess the copy number alteration, somatic mutation, and gene expression, which may identified, and they showed the results identified the clones that pre-existing blast cases initiating clones already at the time of diagnosis. So they took the knowledge from the single cell analysis to develop the multi-color flow cytometry panel. It is known that chronic phase CD34 positive cells from high risk chronic phase harbor a common blast phase like gene expression. So they developed the protein-based biomarkers based on transcriptomic analysis. They identified lineage-specific inflammatory signatures that were translated into the practical multiparameter flow cytometry, and also they included panel detecting the megakaryocyte expansion that is present in both lymphoid and myeloid blast phases patients, and also lymphoid progenitor expansion detection, which occurs in patients progressing to lymphoid blast cells. So they finally work with this 4 panel. and they perform several technical validation and also clinical validation. And this is one example of the clinical validation in imatinib-treated patients. They work with patients at the time of diagnosis who were then treated with imatinib or second cohort by stem inhibitors. And during follow-up, they know that there were patients who progressed to myeloid blast phase or lymphoid blast phase, but they performed the multiple flow cytometry in these patients at the time of diagnosis. This is quite busy slides, but what I would like to show that the MFC analysis showed 100% sensitivity and very high specificity, and is outperform, let's say, the result from ELTs or so-called score. So they believe, Tiong Wong and his colleague believe that MFC may be a complementary tool to the ELTS score. If we can see in the pooled cohort of patients, the actual outcome, patients remain in chronic phase, and patients who transferred blast phase, there were 13 patients, and indeed MFC predicted more accurately the high-risk patients than ELT score. So this is really a highly promising tool to be introduced in the clinical practice in the future. Another very interesting work was provided by the talk of Teng Wang from China, and their study focused on CML leukemic stem cells persistence. Due to they focused on the metabolism pathway in this leukemic stem cells. In their previous work, they showed the dynamic changes in adipocytes within the bone marrow microenvironment of newly diagnosed CML, and by the lipidomic profiling of bone marrow serum of CML patients and healthy donors. They showed that there is a significantly elevated level of palmitic acid, and moreover, palmitic acid was found to be significantly elevated in patients with a poor response to TKIs compared to optimally responding patients. So in this work, they perform in vitro and in vivo functional experiments. They treated CD34 positive leukemic stem cells or imatinib resistant stem cells with the palmitic acid, and this enhanced resistance of CML cells, which was evidenced by the decreased apoptosis by reactivation of cell cycle and increased proliferation capacity. And in an animal model, they established BCR-ABL-driven CML mouse model, and they treated the mice with imatinib in combination with palmitoylation inhibitor to bromopalmitate, and this lead to a significantly prolonged survival of the mice, and also markedly reduced spleen size of this combination treated mouse. They uncovered the pathway that palmitic acid upon imatinib intervention may significantly upregulate the expression levels of the genes associated with the interleukin 6.3 signaling pathway, and then also they focus on the ZDHAC family of palmitotransferases, and they found the particular as the HHC19 enzyme as a critical responsible for palmitic acid activated palmitoylation in CML leukemic stem cells. So finally, they believe that palmitic acid activates JAK1 STAT3 via the HHC19 which lead to palmitoylation in enhanced palmitoylation in CML leukemic stem cells that result in their stemness, cell growth, and resistance to TKI therapy. And they believe that the development of selective SDHC19 inhibitors may offer novel strategies to eradicate resistant leukemia stem cells. Michele Cibodo from Saturn Ustioki lab in their work they aimed to found how non-BCR-able somatic mutations, the level of resistance of non-BCR-able somatic mutations on tyrosine kinase inhibitors, whether there are differences, and they focused on imatinib and asciminib. They applied in their work the crop sequencing, which is the technique that they developed. They worked with the CML cell line that expressing CRISPR-Cas9. Then they transduced the cells with the custom gene panel, lentivirus cgRNA library of 35 genes. There were two categories of genes. Some were progression-associated genes, for example, SXL1 and RAMS1, and some derived from a previously published synthetic CRISPR screen. And the transduced cells were treated with the vehicle imatinib and asciminib, and then they performed other analysis, and the results were that the expression profiles of all the resistant gene knockout with the imatinib or asciminib treatment were the upregulated pathways within the two TKIs were mostly similar. So this include mTOR pathway, unfolded protein response, and apoptosis. And they investigated the pathways in further research. They found that most of the non-BCR somatic mutations in CML, like TET2 or RAMS1 and others, did not result in differential sensitivity to imatinib or asciminib. However, interestingly, they found knockout of the gene BCR. They worked with the knockout K562 cell clone, and they demonstrated that this knockout, the BCR knockout, was resistant to asciminib, but not to imatinib, which is the graph shown here. This is the number of the cells after 4 days growing in the presence of the DMSO, imatinib, and asciminib. So this BCR knockout cell line or cell clone was resistant to asciminib. And then they performed a combination drug library to find the combination treatment to overcome the resistance of these cells. And the highest score was found for combination of asciminib and the inhibitor BCL-XL. BCL-XL is the anti-apoptotic protein from the BCL2 family. So the conclusion of this work was that understanding mutation-specific resistance mechanism could enable rational combination approaches to overcome resistance. And a combination therapies were presented by Adam Laznička, by my colleague, using the PDX model of a blast phase CML. He presented 4 PDX models that were established from the blast phase CML patients at the time of diagnosis or during TKI therapy and progression. All the PDX model patient-derived xenografts were treated with solo therapy, monotherapy, ponatinib, asciminib, venetoclax, and their combination. And this is example of one PDX model of that was established from 58 years old female. She was diagnosed in blast phase CML with the mixed phenotype, but the PDX was established from the first relapse with the myeloid. phenotype, the karyotype was complex, BCR mutation T355 E250K and E459K, and other mutation highly pathogenic RANKS1 mutation. Ex vivo, the blast showed monotherapy venetoclax resistant, but in the combination therapy, ponatinib and asciminib of this PDX model was significantly improved event-free survival, and more better combination therapy, ponatinib and venetoclax, compared to other treatment regimes. And he concluded the PDX model captured the biological complexity and clonal diversity of CML blast phase, because all four PDX model from blast phase CML patients differed from the genomic aberrations and cytogenetic aberrations. And it was interesting that we found a consistent benefit of combining ponatinib, asciminib, and venetoclax across the multiple PDX models. And this provides a strong rationale for the prioritization in clinical management, which is in relation to other previous work. And Adam believes that more clinical trials are needed to guide optimal drug combination choice, dosing, and treatment scheme to improve outcomes of patients with CML in blast phase. So this was the last slide from of my talk. Of course, there were other interesting work, and I have to say that all the researchers that presented their work try to find to deepen knowledge what is behind the leukemic stem cells persistent and causing the relapse after TKI cessation or progression to blast phase. And I hope that we will continue in this, and I'm really believe that the one that there'll be really path to cure CML. So thank you very much for listening.
Thank you very much, Kateřina, for this really dense presentation. And it's amazing to see all these different approaches. And would be lovely to discuss into more detail how these may translate into clinical practice in the future. We're a little bit ahead of time, but I think it's definitely worth taking the time for a Q&A session. I've seen that there were a couple of questions from the audience in the chat. As far as I've seen, so we have 2 clinical questions to start with, then a question to you, Kateřina, and then a couple of more overall question that brings both perspectives together. Andreas, I'd like to start with one question from Timothy Hughes. I read it out. The TFR rate of 58% in the TFR2 study you presented is remarkably good and contrasts to the much lower rates of TFR in the Canadian study. In TFR2, where the rate was closer to 30%. Any insights from you into which we see the difference?
There's actually a discussion ongoing in the chat. Jane responded to
Yes.
Tim's question as well. It's indeed the case compared to many other studies with the second TFR attempt. These are very good results. I think it's, of course, part of it's that the prospective study with very well-defined patients, centralized monitoring, well-structured. I don't think that the other studies had not strict requirements, but I just know that this study from Susanne had these requirements, and I think that's important. Actually, I think it's a play of chance here, which patients had been recruited with which biological backgrounds. We know that this is very heterogeneous, and we, of course, worldwide, there are studies ongoing, preclinical studies ongoing, what can predict the first and second treatment-free remission. I think that's a good example here, and I think we need to go into the details, actually, what the reason for this very favorable response rate here in this case is. And I think Susanna and colleagues together with Markus Firman will do this in the next months and in the next year.
Interesting. So next question to you, Andreas, is, Kateřina, please feel free to comment, but it's rather clinical related, is a question from Giora, so representing the patient community. From all new TKIs in clinical development, including those you could not cover, like Terns or olverembatinib, which one, from your perspective, looks most promising to you? And are they targeted to all patients or specific patient groups only?
I would never say that, what is most promising, because they are all different. And I'm very happy that we have so many drugs available to be very individual, very specific to each individual patient in second, third line, and so on. Of course, asciminib is for me, for the first line treatment, if available in a given country, of course, the drug of choice. But it's, as we know, not reimbursed in most countries worldwide. We have it available in Germany now, and we have good experience with asciminib. Terns was not deleted from me, not omitted. I could not cover this question. It was not presented at EHA. This has a reason. The reason was that the Terns company, a small company in the United States, merged with Merck, and in Europe, MSD. And therefore, within this merger, the new study has not started, and the data from the phase 1 were presented by Elias Jabbour at ASH, and they are very beautiful. That means there was no new data which could have been presented here at EHA. But of course, the Terns drug is a very good allosteric inhibitor as well, with very positive data. And Giora asked for exclusions. I think the only exclusion for the Terns drug and asciminib are the patients who lack the exon A2 of ABL, because it will not work in these patients. In all other patients, it can be used. And olverembatinib, we have seen many presentations by the colleagues from China in the past on the different stages of olverembatinib development in chronic phase, accelerated phase, and also blast phase. It's very similar to ponatinib from the molecular structure. Side effect profile is a little bit different, but there was nothing new here at EHA. Therefore, I didn't omit it. It was not that formally presented, and therefore not so important for this presentation here.
Okay, thank you. So moving on to you, Kateřina, or the more biological part. Before I read out a very specific question here from the chat, I'd like to get your opinion, like on a more broader scale, from all the approaches you presented and some others that were presented at EHA, like immune surveillance, bone marrow microenvironment, and all these new approaches. Which of these insights do you think would translate best into clinical practice or in the near future? What is your perspective?
I believe that one day that the technology is still improving, that one day we will be at the time of that we all can perform this single cell analysis, because this may significantly precise the diagnostics and define the subtypes of CML, like really precise the high risk chronic phase patients who may really inappropriately respond to TKI therapy and be in risk of disease progression. But there is still several years we are still quite far from this future to implement in clinical practice routinely single cell analysis. Yes. So, but I believe that what was presented by Professor Tiongong, the flow cytometry, multicolor flow cytometry, this may be implemented quite easily because some multicolor flow cytometry is routinely performed in other diseases like in acute lymphoblastic leukemia, etc. So this may be a tool in the future. And I believe that also the bulk RNA sequencing, which is in other hematologic disorders routinely used in clinical practice, like I already mentioned the acute lymphoblastic leukemia, that I believe that our research will show that also the RNA sequencing, bulk sequencing may improve the risk stratification patient already at the time of diagnosis. And this may be implemented quite easily.
Kateřina, I think when we consider all the predictors for TFR now, I think it's important to differentiate what we need in the future for clinical decision and what is biologically, academically interesting. Of course, we want to discover everything which is ongoing biologically, but I think with the very low risk, if any risk of discontinuation, with our clinical definitions, deep molecular response for a year and 3 or 5 years of therapy, we are in a very good position if we do that according. But of course, we want to know everything biologically. But if this is really applicable to clinical practice is a question for me.
It is the question, and we need to find the optimal way. And of course, we need to convince you clinicians that the tools that we develop or bring will be very good for you to improve the clinical decisions. So I think that we need to find the optimal way. And yeah, this is. But I of course I agree with you. Yeah, we need to be.
Interesting discussion. So we could move on. There's one final question regarding CAR-T that is widely discussed or implemented already in other disease areas. So any insight regarding CAR-T in CML, specifically advanced phases, or its biological or immunological implications?
Kateřina, do you want?
Kateřina, I think it's...
I don't know about any clinical CAR-T cells in CML. I know.
There are a few case reports with CD19 CAR-Ts in lymphoid blast crisis, but only a few, and not a systematic study. And I think it might be useful in case of refractoriness, but these are single cases only. I don't see that. I think what we publish in the guidelines is a combination of chemo with signal transduction inhibition and of course allotransplant. I think allotransplant should dominate here over any other immune therapy.
Yeah, I agree. Yeah.
So before we close this meeting, Andreas, Kateřina, any closing remarks from or any additional perspectives you'd like to share with us?
No, just thank you. Just thank you for the preparation and that we have an ongoing exchange of ideas. And I think everybody should meet in Göteborg in September, October. Yeah, October, I think.
Yeah, sounds good. And we will definitely cover highlights from the John Gottman conference in another ICMLF conversation here. Just to let you know, this conversation will be made available on the ICMLF website within a couple of days. We have also summaries of key sessions available on our website. So if you haven't seen them, please check the events page or the news page on the website. And if you haven't subscribed to our newsletter and like to get CML news, you can use this QR code here to put yourself on the subscription list. Yeah, it's time to thank you, Andreas and Kateřina, again for making this possible, for being part of the series, and for sharing your expertise and also your personal perspective on the highlights of the meetings. A big thank you to all of you for joining and for submitting your questions. It has been a pleasure. And yeah, we hope to see you again.